Okay, sir. We are on live and we are starting session, sir.
Yeah.
So, very good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. The topic for today's webinar is ovulation induction for IUI. I welcome all the participants. I request them to post their queries, if any, in the chat box, so that we can have a short Q&A session at the end of this presentation. And now it's time to introduce our invited speaker for the day, Dr. C.R. Vijay Kumar, sir. Sir has done his MS DNB fellowship in urogynecology and FICOG. Sir is currently the professor at Ambedkar Medical College, Bangalore, and also associated with Gynecare Hospital, Bangalore as medical director. And sir is also consultant at Motherhood Cloud9 and CMH. And sir has been invited as surgical faculty at national and state workshops. Sir has also have various national and international journals to his credit. Sir's area of interest is laparoscopy, urogynecology, and vaginal surgeries. So, with this short introduction, I welcome you, sir. Over to you
Thank
for
you.
your presentation, sir.
Thank you. Are the slides visible?
Yes, sir.
Am I audible?
Yes, sir. Very much.
Yeah. Hello, good evening, Dr. Stalin. So I thank you for giving my introduction. So today's topic is the ovulation induction for intrauterine insemination. See, ovulation induction is a general topic which defines the using of the pharmacological agents, so has to induce the graphene follicle development, either one or many. This today's topic comprises of the ovulation induction, which is done for the intrauterine insemination only. So why we should do the stimulation of ovulation induction for the intrauterine insemination? There are few reasons why we do the ovulation induction. One is for the improvement of follicular growth. In the natural cycle, what happens? Either the follicle may be growing appropriately or not, but when we are doing the ovulation induction, we ensure that the egg development happens and will be achieved to the satisfactory state. And not only that, we also want to increase the number of follicles. In a natural cycle, we see either one or two of the follicles will be maturing. But in ovulation induction, the aim of the ovulation induction would be always to have either 2 to 3 eggs in each cycle, so that when the IUI is done, the chances of the pregnancy will be high. It is also done as a treatment for anovulation. As you know that the today's most of the cases come under the PCOS. In PCOS, it is nothing but the chronic anovulation. In such cases, when we are planning for the IUI, we should ensure that the anovulation is prevented and treated with the ovulation induction drugs. Thereby, the appropriate size egg is formed in order to have the pregnancy as a treatment for the PCOS cases, those who desire the fertility. One more reason why we do the ovulation induction is for a better timing of the IUI. As you all know that the IUI is appropriately is ideally done at about 36 to 40 hours post LH surge. Either in the natural cycle, the post LH surge can be detected and done at 36 to 40 hours, or else in the ovulation induction, once the appropriate size of the graphene follicle is achieved, then the HCG is given, which mimics the LH surge. The timing of the HCG injection is considered as the LH surge, and 36 to 40 hours later, following the injection, the IUI can be timed. It also helps in the improvement of luteal phase. So this is especially important in the cases of the polycystic ovary syndrome, wherein because of the chronic anovulation and because of the immature follicles, the luteal phase would be defective. So although the fertilization happens, there will be most of the cases come under the medical pregnancy, wherein only the HCG would be detected, but subsequently we fail to detect the gestational sac. So in such cases, it becomes all the more important that the graphene follicle reaches the appropriate size so that it would be mature enough for it to have a mature corpus luteal formation, which leads to the adequate progestogen secretion. Thereby, the pregnancy will be more successful. So as I said, the optimum ovarian stimulation for IUI is that we should have at least 2 to 3 follicles which are about 18 to 20 mm size. So this is the scientifically proven that the 18 or more than 18 mm size of the graphene follicles, they will be mature enough for it to release the ovum, and later it forms a mature corpus luteum in order to lead to the successful pregnancy. Not only the number of follicles, even the endometrium should be of the proper thickness and the echo pattern. We consider anything more than 8 mm thickness of the endometrium as satisfactory in ovulation induction. And it is also understood that the endometrium has to be in the trilaminar. That is, there should be 3 lines. The outer 2 lines will be the endomyometrial junction, and the inner 1 line will be the endometrial cavity, which mimics as a line. So it is understood that this trilaminar pattern of the endometrium is more appropriate for the reception of the fertilized ovum and thereby leading to the successful pregnancy. We have also seen in some of the cases where the endometrial thickness may be more than 8 mm, but the echo pattern will not be the trilaminar. So in such cases, the pregnancy rate comes down. So for that reason, we tend to have this type of echo pattern. There are so many topics on this bad endometrium, and when we discuss about the endometrium, it itself is a vast subject. So in order to have a good the endometrial echogenicity, some of the practitioners, they are in the habit of using many of the drugs which improves the endometrial quality. It could be the estrogen, or it could be the sildenafil citrate, it could be the ecosprin, like so forth. So there are so many agents which are used for having the good endometrium. So just ovulation induction doesn't comprises only of the using of the pharmacological agent in order to have the good graphene follicle, but also we should see to that the endometrium is also of the proper quality, and the IUI has to be done at around day 14. It could be day 13 or day 16. As I said, the IUI timing has to be done with the HCG injection about 36 to 40 hours after the HCG injection is given. So now the question comes, why controlled ovarian hyperstimulation? So what is, before we get into the reason for controlled ovarian hyperstimulation, we should know what is the exact meaning of the controlled ovarian hyperstimulation. As I said before, it is the adequate use of the pharmacological agents in order to have good number of the follicles, and they come to the appropriate size of about 18 to 20 mm. So this is kept in mind before we start any pharmacological agent. So why controlled ovarian hyperstimulation? It provides, as I said, it provides more number of follicles with good quality. That is important. And the timing of HCG injection predicts ovulation better, so as to schedule the IUI near ovulation time. So it's very important that the IUI is done at the time of the ovulation. If you do the about 48 to 48 hours before or after the ovulation, then it doesn't make any sense in doing the ovulation induction. Controlled ovarian hyperstimulation offers more for the fertilization and implantation. Hence, it increases the conception rate. It also corrects the subtle endocrinopathies which block ovulation or implantation. As I said before, either it could be the defective luteal phase or it could be the improper endometrium. These are some of the reasons why there could be the subfertility. So, in a woman, although there is the ovulation happening, but because of the either the corpus luteal defect or because of the defective endometrium, she may not be able to conceive. So in ovulation induction, these kind of the subtle crinopathies will be corrected, thereby increasing the chances of conception. So in whom we do the ovulation induction for IUI? Coming to the male factors, it could be the retrograde ejaculation, impotence or ejaculatory dysfunction, hypospadias cases, hypospermia, where there is very low volume of the sperms, non-liquefying or high viscous semen. This is commonest finding what we see in the today's practice. The semen sample will be highly viscous. It takes, instead of just half an hour for liquefaction, it may take 1.5 hours to liquefy. This indicates that the poor fertility in a male factor, and this is a one of the commonest indication for the IUI. The other the factors are the subnormal semen parameters. If we suppose the semen, the sperm concentration is about just 10 to 15 million sperms per ml, or the mortality may be reduced. In such cases, although we cannot categorize them as the infertile patients, but definitely they will be the subnormal semen parameters. They are the ideal candidates for the IUI, and that gives the good results. Even the one more common reason is the seminal anti-sperm antibodies. How do we detect? When we do the semen analysis, we understand that the sperms will be having, instead of the forward motility, they may be having the rotatory motility. So the rotatory motility of the sperms indicates that there could be high concentration of the anti-sperm antibody. By doing the IUI, we tend to do the washing of the sperms, and thereby these antibodies are washed away, and the sperms will be rid of from all these the anti-sperm antibodies. And since we are inoculating the semen sample directly into the uterine cavity, even the cervical factor and the anti-sperm antibodies which are present in the cervical mucus is also bypassed, thereby increasing the chances of the conception. The one more last reason why we do IUI is about the unexplained infertility. The couple would come, they will have all the evaluation, and during evaluation, we come to know that all the factors are normal. There is no significant factor which is causing the infertility. So such candidates, we call it as the unexplained infertility. Although this is not the first line of management, later, if the with the simple ovulation induction and with the counseling of the timed intercourse, in spite of these two things taken care, if the couple fail to conceive, then we may subject them for the IUI. Coming to the female factors, it could be vaginismus, the cervical hostility, what I said just before, the cervical mucus may have the high concentration of anti-sperm antibodies that could lead to the reduced fertility rate. Even the ovulation induction. So the best example for this ovulation dysfunction is the PCOS. In such cases, although the patient may be having the oligomenorrhea, and some patients may have the regular cycle. In such patients, the ovulation would have not been happening. So, by doing the ovulation induction with IUI, so this the problem would be taken care. Even the mild endometriosis, as you all know that the mild endometriosis, wherein there is no significant the ovarian chocolate cyst, only there could be the few deposits seen in the peritoneum or in the pouch of Douglas during laparoscopy. In such cases, the ovulatory dysfunction would be commonly seen in cases of mild endometriosis. So, again, in ovulatory dysfunction, the ovulation induction with IUI would be the most appropriate. That's why in mild endometriosis, the ovulation induction and IUI is done. Coming to the other reasons, the allergy to the seminal plasma. This is also not that commonly seen, and again the unexplained infertility. So in the IUI, there is the two types. Either we can utilize the husband semen sample, or else if the husband semen sample is of very poor quality, then we may have to do with the IUI with the donor sample. But before we do the donor sample IUI, a consent has to be, proper consent has to be taken from the couple, and they have to be explained about the plan of the treatment, because the legal issues will be that if we are not able to convince them and take the consent from the couple, that becomes a bigger issue, especially in these days. The other thing is, always the donor sample has to be matched with the husband characteristics. Either it could be the height, blood group, the color, all these the few important the phenotypic features has to be matched before we select the donor sample. The indication being the azoospermia with testicular failure. So, see, azoospermia can also be because of hypogonadic, hypothalamic hypogonadism. In such cases, we can treat. But if there is a testicular cause for azoospermia, it cannot be treated. In such cases, it's better we take the donor sample. But before that, we can even try with the PISA-TISA in order to retrieve the husband sperms. Severely abnormal semen parameters. As I told, sometimes there will be severe oligoasthenospermia. The motility will be very less. So, and the abnormal sperms will be in excess. In such cases, if the IUI with the husband sample fails for consecutive 3 to 6 cycles, then it's better to utilize the donor sample. Hereditary disease in man. So this also becomes a reason for IUI. Severe untreatable Rh isoimmunization in wife. So if the wife is Rh isoimmunized and there is subsequent the repeated pregnancy loss, in such cases it becomes very important to have the conception with the donor sample of having the blood group of the Rh negative. So if the husband, if the donor sample is also Rh negative, then this solves the problem of Rh isoimmunization, and she can have the successful pregnancy with a good the outcome. Repeated failures with IVF or ICSI. So again, if the parameters, these sperm parameters, the semen parameters of the husband is not of that good quality, and if there is successful the IVF or ICSI failure, in them also you can have a try of the donor sample IUI. Or in nowadays there are so many the lesbian couples, even there are single women who desire to have the pregnancy. So in such cases also you can utilize the donor semen sample. So what are the ovarian stimulation protocols before we time the IUI? It could be the simple the ovarian stimulation always has to be a simple method. It has to be a cost effective, because most of the patients may not be able to afford for the gonadotropins, which are very costly, and there should be minimal side effects. So, and the success rate should be a good one for accepting the ovulation induction agent. And a patient requiring ovarian stimulation or induction can be categorized in two groups. Group one is the ovulatory patients, that is already the patient is having the regular cycle with the regular ovulation, but still you want to have, instead of just one single follicle, you intend to have the 2 to 3 follicles. In such cases you have to do the ovulation induction. In these patients there is an established ovulatory pattern, and multiple studies have shown that the improved pregnancy rate with ovarian stimulation in these patients as compared to the non-stimulated natural cycles. Suppose if the single follicle is there, then compared to the single follicle, if there are 2 to 3 follicles, then definitely arithmetically we can expect that the success rate would be much better than a natural cycle. As I said, the ultimate aim in the ovulator patient is that we should have the multiple follicles, 2 to 3 follicles. Usually the determination of the follicles will be taken in the first 5 days of the menstrual cycle. So in the ovulation induction drugs has to be utilized in that time in order to increase the chances of development of multiple the graphene follicles. Coming to the other type of the patients is the anovulatory patients. They fall about, they are about 20 to 30% of the cases of the female infertility, and anovulatory patients can be further divided by WHO into 3 categories: hypogonadotropic hypogonadism, where there is defective the production of the gonadotropins. That will lead to the subnormal functioning of the ovaries. Second group comes under the PCOS comes under the second group, and third group is ovarian failure. Always it's understood that the group 1, that is the hypogonadotropic hypogonadism, has got much favorable outcome, because the ovaries will be a normal and they will be ready to respond to the gonadotropins. Only because of the hypogonadotrophism, the ovarian function will be suboptimal. Once we start the patient with gonadotropins, there will be the beautiful recovery of the ovarian function, and there will be good development of the graphene follicles, what we see in our day-to-day practice. The second, the another the difficult aspect is the PCOS. In the PCOS, what happens? The either because of the genetic abnormality or because of the internal hormonal milieu abnormality, the ovarian function will not be appropriate. There will be multiple small follicles, immature follicles, which will be failing to reach to the appropriate size, and they fail to mature to form the graphene follicles. In such cases, it becomes very important that we establish a right hormonal internal milieu in order to have the successful ovulation. The third one, that is the ovarian failure, is the most difficult category to treat, because in these cases, the ovary will not be in a proper stage in order to respond to the gonadotropins. So whatever type of treatment you give, the ovary fails to have the good follicles. So that becomes a challenging. So out of these three, if anybody wants to wish, they can have the hypogonadotrophic hypogonadism for a successful the outcome. In the anovulatory patients, it's always the aim is to have the monofollicular development. Compared to the ovulatory patients, here we tend to have at least one single egg which reaches the appropriate size to have the successful pregnancy. Because in such cases, what happens, there won't be any follicles development. So in this situation, at least one the follicular development will be of great help, and thereby it prevents the one of the most common complications what we see in the ovulation induction, especially in cases of the PCOS, that is the OHSS, ovarian hyperstimulation syndrome. In such will be common in a cases where the excess dose of the ovulation induction drugs are used, and thereby leading to the multiple follicular development. So in such cases, we have to cancel the cycle, and the success rate will come down drastically. So aim should be for monofollicular development. So as I said, there are various the stimulation protocols. Either we can do the IUI even in the natural cycle, but here the success rate is about the 3.3%. But in some cases, the IUI can be done with the clomiphene citrate usage. Clomiphene citrate is used for the ovulation induction, and the IUI is timed at the time of the ovulation. So again, here the success rate is about around 10%. Along with the clomiphene citrate, if we use the HMG for the better development of the graphene follicle, and then we do the IUI, the success rate is about the 13%. Instead of that, if we use only the HMG and we avoid using the clomiphene citrate, and then we do the IUI, the success rate would be about 17 to 18%. So as you increase the number of ovulation induction agents, and if you increase the cost of the ovulation induction agents, definitely the success rate would be good. But in common clinical practice, it's very appropriate that we use both the clomiphene citrate and the HMG for the development of the graphene follicle, but in a lesser dosage, and for minimal days, so that it becomes cost effective, and even we can match the success rate with that of the only HMG cycles. So what is the success rate depending on the number of follicles? Suppose if the patient is having only one follicle, then the success rate with IUI is about 5.7%. Instead of that, if there are two follicles, then the success rate is about 13%. If it is 3, it will be 16%, and if it is 4, it will be the 14%. As you can see in this slide, it is always the success rate would be appropriate if the follicles is about 2 to 3 rather than 1 or 4. As I said, one follicle, the success rate will be very less. Although the success rate is impressive with the 4 or more follicles, but the problem comes with the OHSS. Always, if there are more number of follicles, the complications will be more. Not only OHSS, even the multiple pregnancy is also a big issue, although the woman becomes pregnant. So how do you go about before you start induction? It's very important that we do the day 2 FSH. So why we have to do the FSH? FSH indicates the ovarian reserve. Although there are many other investigations which are more specific and more sensitive than FSH nowadays, but many of the centers, they tend to do the one FSH evaluation on the day 2. Suppose if it is more than 10, then it indicates the poor ovarian reserve. Instead of FSH, we can utilize the anterior follicle count, antral follicle count. Again, the antral follicle count is done on day 2 or day 3 in order to note down how many primordial follicles are starting maturing enough to form the Graafian follicles. It is understood that in a normal fertile woman, about 2 to 3 the antral follicles will be seen in each ovary, and this indicates that the fertility outcome would be good. The other parameters are the ovarian volume. Again, the ovarian volume indicates the if the in the cases of PCOS, the ovarian volume will be more, and in such cases, because of the echogenicity of the ovarian medulla, the increased chances of the hyperandrogenism will be there. The other parameter is the AMH. AMH is a very ideal tool in order to estimate the ovarian reserve, and about 3 to 7 value indicates the good ovarian reserve. Apart from these, the tests in order to note down the ovarian reserve, some of the other tests also has to be done in order to note down whether there is tubal patency or not. So this can be done with the HSG, or if in some cases we can do the hysterolaparoscopy in order to confirm the tubal patency. Apart from tubal patency, we can also evaluate the peritoneum and the endometrial cavity in a case in hysterolaparoscopy. So I was telling you about the investigations which are necessary for ovarian reserve. So why ovarian reserve has to be understood? Because if there is the adequate ovarian reserve, then the stimulation protocol will be entirely different compared to the woman who is having the poor ovarian reserve. And in some cases, in the cases where there is a good ovarian reserve, the ovulation induction can be done with the simple agents like Clomiphene citrate or letrozole. In cases where there is a poor ovarian reserve, you have to utilize the gonadotropins, although they are costly, but utilization of gonadotropins for such women will lead to a appropriate number of follicles and of adequate quality. So what are the agents which are used for ovulation induction? The commonest the molecule what we use is the Clomiphene citrate. Apart from Clomiphene citrate, letrozole, gonadotropins can also be utilized. In some cases, we can combine these agents like Clomiphene citrate with gonadotropins, letrozole with gonadotropins, gonadotropins with GnRH analogs, gonadotropins with GnRH antagonists. Again, the purpose of using the gonadotropins with along with the Clomiphene citrate is to reduce the cost incurred for ovulation induction and simultaneously improve the follicular development. So suppose if we use only the ovulation induction, so what is the consumption rate? And what is the consumption rate when we do only the IUI without using the ovulation induction? If we combine the ovulation induction with the IUI, per cycle there is about 33% chances of the pregnancy compared to only 18% for IUI alone. So controlled ovarian hyperstimulation has independent positive effect on pregnancy rate, especially when combined with IUI. That is the reason always the IUI has to be done along with the ovulation induction. In young patients without a prior pelvic surgery and with good post-wash semen quality, controlled ovarian hyperstimulation doubles the IUI pregnancy rate. So if there are no other factors apart from if there are no other significant factors, then the controlled ovarian hyperstimulation with IUI will be having a good success rate. So coming to the clomiphene citrate, it comes in many dosage, 50 milligram and 100 milligram. The dosage can be initially, to begin with, we have to start the 50 milligram once daily for 5 days. Although textbook mentions that it has to be started on the day 5 of the menstrual cycle, but most of the practitioners nowadays start the clomiphene citrate from the day 3 of the cycle, and even some consultants, they start the clomiphene citrate on the day 2 itself. Usually the ovulation occurs 5 to 12 days after the 5th dose is taken. If the ovulation is documented but pregnancy does not occur, the same dose of the clomiphene citrate is used in the future cycles. So how do you monitor whether the woman who is on the clomiphene citrate is having the ovulation? This can be done by utilizing the ultrasound, especially the TVS. The follicular scan has to be done serially in a woman, either to start with on the day 8, 11, 13. Thereby we can monitor the follicular development, as well as you can confirm that the woman is whether having the ovulation or not. Suppose with the clomiphene citrate with the 50 milligram dosage, the woman is having ovulation, then although she doesn't conceive with the present cycle, again in the next cycle, the same dosage, that is 50 milligram, has to be continued until about 3 to 6 cycles, until she will be having the evidence of the ovulation by follicular scan. Suppose if the ovulation doesn't occur, then you can increase by the dosage of clomiphene citrate by about 50 milligram. Suppose she was taking previously 50 milligram, you can increase it to the 100 milligram OD for 5 days. Likewise, you can go on increasing the dosage up to as high as the 250 milligram. So generally we consider that if the woman fails to ovulate in spite of 150 milligram dosage for successful 3 cycles, then we consider as she is resistant to the clomiphene citrate. In such cases, it's better you change the ovulation induction drug either to the letrozole, or you can start only the gonadotropins. So how does the clomiphene citrate act? Basically, it's the serum which blocks the estrogen receptors. The estrogen receptors are present in various parts of the body, starting from the pituitary hypothalamus to the endometrium, the cervical mucus. So generally the clomiphene citrate is considered as a centrally acting ovulation induction agent. because it goes and blocks the ER receptors which are there in the pituitary and hypothalamus. Once it blocks, the negative feedback effect which is seen with the estrogen is blocked. Thereby, there will be the adequate or excess production of the FSH which will start happening. Because of the excess FSH secretion, the immature follicles which are there in the PCOS cases will start developing. Thereby, the vicious cycle which was there will be cut off, and there will be the formation of the good quality Graafian follicles, and thereby the chronic anovulation, which is one of the hallmark of PCOS, is prevented, leading to the ovulation in PCOS cases, leading to the good successful pregnancy. As I told you, the clomiphene citrate mainly acts as a centrally acting the ovulation induction drug, but it also acts peripherally on the endometrium and the cervical canal. So thereby, the poor endometrium and the thick cervical mucus are a constant factor which are seen in a woman who is being treated with the clomiphene citrate. This is nothing but the flow chart. How do you manage a case with the clomiphene citrate? As I told you, the dosage can be slowly increased for about the 100 milligram. Again, for 3 cycles, we can see if she doesn't have ovulation, again, you can increase it to 150 milligram. So, what are the chances of the consumption with clomiphene citrate? It is about 30%. And what is the failure rate? It is about the 40%. 40% failure rate is considered when she is having successful ovulation, but there is no pregnancy. Suppose if she is not having the ovulation in spite of the CC, we call it as CC resistant. It's not the failure rate. And what is the resistance, or what is the percentage of women who is not having the ovulation is about 25%. And the commonest drawback with CC, as I told, is anti-estrogenic effect, that is about the 5%. So for all these reasons, they tend to use the other ovulation induction agent, that is the aromatase inhibitor. It could be the letrozole, which comes in the dosage of 2.5 to 5 milligram, or it could be the anastrozole, the 1 milligram. Basically, these molecules are the aromatase inhibitors. They were started, the usage was started in the humankind for the breast cancers in the beginning. Then its use for the ovulation induction was also evaluated, and nowadays this becomes the second best molecule for the ovulation induction apart from the clomiphene citrate. So unlike the clomiphene citrate, the letrozole is a peripherally acting molecule. So as you all know that in the PCOS or in any other chronic anovulation, it's the failure of the androstenedione getting converted, the androstenedione, which is excess in amount, will be converted to the estrogen. So this estrogen further acts on the hypothalamus, leading to the reduced secretion of FSH. So the letrozole is a aromatase inhibitor, which will inhibit the conversion of androstenedione to the estrogen. Thereby, the circulating estrogen concentration will be reduced and further lead to the positive feedback from the hypothalamus, and that will lead to the increased secretion of the FSH, thereby leading to the development of the better Graafian follicles. So, unlike the clomiphene citrate, it doesn't act on the endometrium and cervix. Hence, the good endometrium and the favorable cervical mucus can be expected with the clomiphene, with the letrozole. And that's why if to begin with, we always start the clomiphene citrate. If there are the increased or significant failure rate with the clomiphene citrate, then we tend to choose the other molecule, that is letrozole. The another important thing about letrozole is that in clomiphene citrate, we usually see there will be simultaneous development of the about 2 to 3 follicles. But in letrozole, we tend to see only there will be monofollicular development. There won't be multiple follicle coming up, only there will be single follicle. And this is the reason why we see the multiple pregnancies in clomiphene citrate, not in the letrozole. So in the few years back, there was so many articles which had come telling about the teratogenic effect of the letrozole on the fetus, and this was the reason why the FDA had banned the usage of the letrozole. But later, some significant studies have been done, and there is a much favorable outcome which tells that the letrozole doesn't have any teratogenic effects on the fetus, and again there will be continued usage of the letrozole apart from the clomiphene citrate. Apart from these two molecules, there is one more, that is the gonadotropins. This is also used for ovulation induction. Usually, basically, we have to use the FSH, but since in the earlier days, there was no appropriate technology for the manufacturing the pure FSH. We tend to use the urinary concentrate, that is human menopausal gonadotropins. That was the standard usage of the gonadotropins. The gonadotropins were extracted from the human menopausal urine concentrate. Later, with the advanced technology, we have the availability of the recombinant FSH and the pure the FSH. Again, the monitoring will be done with the ultrasound, that is follicular scan. Trigger ovulation with HCG when follicular maturity is attained, and it significantly improves the pregnancy rate because it just doesn't go on treating the basic vicious cycle, but it instead replaces the endogenous gonadotropins and directly starts stimulating the ovaries to have the follicular development. Again, since there will be multiple follicular development, the risk of multiple pregnancies will be common in cases of gonadotropins. As I said, the advantages are the high efficacious, and the ovulation induction will be of high success rate, and the conception rate is about 20 to 30% per ovulatory cycle. But the major limitation is that since it can lead to the OHSS, such complications can happen. Even multiple pregnancies are quite common with the gonadotropins. It is also understood that the continued usage of the gonadotropins for n number of cycles will lead to the risk of the ovarian cancer in the woman in the later part of her life. So, what is the choice of the gonadotropins? It depends on the FSH-LH and FSH-LH ratio done on the day 2. Suppose if the LH is higher than the FSH, then we tend to use the more pure form, that is the either the only FSH or the recombinant FSH instead of the HMG. Suppose this type of the scenarios wherein the LH is greater than the FSH can be seen in cases of the resistant PCOS and in cases of the lean PCOS patients. So in such patients, if we want to use the gonadotropins, better use the FSH or recombinant FSH. Suppose if the LH is of lesser compared to the FSH, then you can utilize the HMG. Why I'm telling this is because always the HMG is less costlier compared to the FSH and the recombinant FSH. That adds to the cost of the management of the ovulation induction with IUI. So for ovarian stimulation in patients with hypogonadotrophic hypogonadism, a combination of LH and FSH is used. What are the various regimens of using the gonadotropins? It could be the conventional regimen, which I will be telling in detail, or it could be the step down or low dose step up regime. So these are some of the regimes which we use for using the gonadotropins. So what is the chronic low dose step up regime? So in this, the chronic low dose step up regime, the ovulation induction is started with the usage of very low dose gonadotropins, that is about 37.5 international unit. See, the gonadotropins comes in the two dosage, either the 75 or the 150 IU. So it is started with this 37.5 IU, and slowly it can be increased to 75, and further again it can be increased to 112.5, and then ultimately about 150 international unit. This is because some of the patients who are non-PCOS patients and in whom we are using gonadotropins, for them it's better we start it with the low dose so that they respond very well. And again, in some of the cases of the PCOD patients, especially in the resistant PCOS cases, in order to prevent the formation of OHSS and the formation of multiple follicles, we tend to use the very low dose gonadotropins, so that with the low dose gonadotropins, the controlled ovarian hyperstimulation is done in order to have the only 2 to 3 the follicles. Suppose if we use the very high dose in the beginning itself, then they may land up in having the 10 to 12 follicles, and they may land up with OHSS. And the other method is the step down method. In the step down method, to start with, we start with the high dose, that is 150 IU, then slowly it is reduced to 112, then again 75 and 37.5. Whereas in conventional regime, the very standard fixed dose is started to start with, and to end with the fixed dose, that is either about the 75 IU or 150 IU is done, until the appropriate size of the follicle is achieved. Thereby, after achieving the appropriate size of the follicle, the HCG trigger is given for the ovulation induction to happen. So what are the various parameters we look into before we start the controlled ovarian stimulation? It could be the age of the person, and the FSH, which indirectly FSH, LH, and AFC, that is anterior follicle count, which indirectly tells about the ovarian reserve. Depending on that, we start the gonadotropin dosage. Suppose the patient is elderly, about 35, more than 35 years, in whom the ovarian reserve has come down. In such patients, it's important that you start with the higher dose, because low dose, the gonadotropins will not be sufficient for her. So ovulation induction usually is started, as I told, from the day 2 or day 3, and it depends on the follicular size. It should be less than 10 mm. And most important is you have to do the scanning in order to rule out the cyst, because if the ovarian cyst is there before you start the ovulation induction, then the chances of abandoning of the induction and the failure rate will be high in such cases. Again, you have to check for the endometrial thickness, because if the endometrial thickness is poor, you can add up some of the agents in order to improve the endometrial thickness. So type of ovarian stimulation for ART, you can do it with the natural cycle as well, but better whenever you are going for the ART, it's always important that you induce the cycle with the ovulation induction, either with the CC alone or the letrozole alone, or in combination, or with the gonadotropins itself. Again, the chances of the pregnancy and the type of the gonadotropins and the type of the GnRH, whether it is analogs or antagonists, which one you have to use, depends on these important factors, that is the antral follicle count and AMH. Suppose the AMH is high, so high AMH is seen in cases of the severe PCOS patients. In such patients, it's very important that you do the ovulation induction and put them under the antagonist protocol rather than agonist protocol. And in the some of the cases where the AMH is very low, which indicates poor ovarian reserve, in such cases the flare agonist, that is the GnRH analog, is used along with the ovulation induction drugs. So apart from this, you have to also understand that do they have any other the infertility factors that has to be ruled out and that has to be treated before you start the cycle, and you should also counsel the patient and counsel them about the usage of the ovulation induction and type of the GnRH which we'll be using. Again, the GnRH analogs, whether it is non-PCOS or PCOS patients, as I said, PCOS patients, it's better you do the induction usage of the antagonist rather than agonist. Agonist can be used in non-PCOS patients where the AMH is very low. These are some of the regimens for usage of the gonadotropins and GnRH analogs, which will be too much for you. And this is entirely a different topic. So usually it is said that the antagonists are much favorable, but they are more costlier than the agonists. And antagonist protocol will be useful in preventing the OHSS. Again, there are so many other modifications of the usage of gonadotropins. Each the centers have their own protocol and they have their own method. So again, coming to the another important thing is the follicular monitoring. This will be done with the ultrasound by transvaginal scanning. Usually the day 2 scanning is done in order to have the antral follicle count and to rule out any the cyst in the ovaries. And then onwards, the serial scanning will be done starting from day 8 in order to understand how many the developing follicles are there and what should be the dosage of the gonadotropins if we are giving. And usually normally the follicle grows at about 2 to 3 millimeter per day. And once it is of appropriate size, then we can, which can be monitored by the TBS. You can give the HCG trigger. Not only follicular development, even the endometrial thickness and its echo texture monitoring can be done with the TBS. Some centers, apart from the TBS, they also do the serum estradiol estimation. Serum estradiol estimation helps in understanding the need of the adequate dosage of gonadotropins. This can be done on the day 2 of the cycle, and again it can be done on the day 8 in order to monitor whether the cycle is going for the OHSS. Very important thing is if there are more than 4 follicles or of more than 16 mm, or if there are 8 follicles of more than 12 mm, and if the serum estradiol is about 1500 to 2000 picogram per ml, then it's better you cancel this cycle because they will end up with OHSS. So timing of IUI is always done with the TVS scan, and also in some centers they do the LHSA. LHSA is more important in cases of the natural cycles wherein you are not put them on any induction agent and you are not monitoring with them TVS. Then you can ask the couple, especially the woman, to have the urinary LH estimation. And there are so many kits available which indicate that whether she is having LH surge. Suppose if there is LH surge, then you can ask the lady to come 36 to 40 hours later for IUI for the cases of IUI with natural cycle. Otherwise, we give HCG and then we time the IUI at 36 to 38 hours. So the important question is HCG injection, that is the HCG trigger is necessary? Yes, it is necessary as the LH secreted by the body may not be adequate enough for the ovulation, especially in cases where there are about 2 to 3 follicles. When there are 2 to 3 follicles which are mature enough, then the endogenous LH surge may not be enough for triggering the ovulation. So in such cases, always it becomes the HCG important factor for causing the ovulation. So this comes to the end of this the talk. I thank all for patient listening.
Thank you, sir. Thank you very much for that wonderful and detailed presentation, sir.
Thank
So
you.
let me wait for 1 or 2 minutes for the participants to post
Okay.
their queries, sir. If there is any query, then I'll read out for you, sir.
Sure.
So participants, I request you to post your queries in the chat box so that I can take it to the speakers. Sir, I personally have some 2 questions or queries like.
Yes.
So, what is the role of aspirin, sir? Whether it has any effect
Yeah.
on this implantation, sir? And what is the
Yes.
ideal time to give this aspirin, sir?
So as I told you, there are so many molecules which have been in usage for the having the good endometrium, the ecosprin or the simple estrogen, or it could be the some of the leucine usage, amino acid usage, and so forth. But none of the studies have proven that the usage of the ecosprin is really a significant factor for improving the endometrium outcome. So there is no much positive effect, but still we tend to use the L-arginine, ecosprin, and even in some centers they start using the low molecular weight heparin also in order to have the good endometrial development.
Okay, sir. Sir, we have one more question, sir. Like, which drug is ideal for ovulation induction PCOS? Clomiphene or letrozole, sir?
Yes. So as I told you, there are so many factors which plays vital role in order to select the ovulation induction agent. Suppose the woman is having the severe PCOS, in such cases, the letrozole would be the ideal molecule compared to the clomiphene citrate. But in cases of the milder form of PCOS, the apart from the normal the dosage of the 50 milligram of clomiphene citrate, additional the uh, counseling about the weight reduction and the healthy food habit will give a good result with the initial dosage of the clomiphene citrate of 50 milligram. So it depends. Suppose in the woman is having the poor endometrium, in such cases the letrozole would be ideal compared to the clomiphene citrate. So it's like that.
How many cycles of clomiphene citrate can be tried, sir, for IUI as concerned?
Yeah, clomiphene citrate to begin with 50 milligram for 3 cycles. So when we are monitoring the cycle, suppose if the ovulation is happening, then we can continue with the clomiphene citrate for about 3 cycles. So 3 cycles of the ovulation induction with clomiphene citrate of 50 milligram can be done without IUI. Suppose if she doesn't come in that 3 cycles, then you can go for the same dosage of clomiphene citrate, but with added IUI. So IUI always increases the chances of conception. And again, with the 6 cycles of the clomiphene citrate alone, 3 cycles and clomiphene citrate combined with IUI doesn't lead to the conception. Then again, you have to rework with the patient. Are you missing anything else? You can subject the patient for the laparoscopy, hysteroscopy, and you can rule out any other factors. So again, all those factors can be cleared before again you restart the ovulation induction.
Okay, sir. Sir, one more question, sir. What
Mhm.
is the role of this adjuvants in IVF, sir? IUI, sir, when it comes to role of adjuvants?
So adjuvants is for both the male factor as well as for female factor. The male factor, especially in cases of poor motility semen sample, or in cases of the oligoasthenospermia, in such cases, the usage of the adjuvant drugs, that is the either it could be the antioxidants, L-arginine, all these the molecules can be used, and you can ask the male partner to take these medicines for about 2 to 3 months before we start the IUI, so that the semen parameter may improve. Most of the cases, if there are any significant oligospermia, asthenospermia, there will be definitely some help with these molecules. Coming to the females, again, as I told, there are so many the adjuvant factors. So usage of them, even the sildenafil citrate usage vaginally in cases of poor endometrium before the ovulation induction gives good result, and such molecules may be used, although there is no significant or there is no proven the scientific study which has shown that certain molecules are definitely going to help. These are all the hypotheses, and there is no damage or the adverse effect by using all these adjuvants.
Sir, and one more last question, sir.
Mhm.
When it comes to clomiphene, it has some histogenic effects, sir. Whether it
Mhm.
can overcome with the use of these agents which improve the endometrial thickness, sir.
Yeah, even so, in our practice, when we are doing the induction with the clomiphene citrate, suppose if there is poor endometrium, I tend to start them with the goscreen, and on the date of the cycle, if the endometrial thickness is not appropriate, I will give even the sildenafil citrate, the vaginal pessaries. It can be used in the dose of 25 milligram 3 times a day for about at least 3 to 4 days prior ovulation induction. So these molecules are of some help, especially when we are doing the induction with clomiphene citrate. Definitely, it will be of useful.
Sir, sir, I don't find any other questions in the chat box, sir.
Yeah,
So
yeah.
if you allow us, then we can end the webinar for today, sir.
Okay. Thank you.
Thank you, sir.
Thank you
Thank
for
you
the
for
opportunity.
being with us today and spending your valuable time with us today, sir. It was a nice
Thank you.
opportunity to learn new things from your presentation, sir. I'd also
Thank
like
you.
to thank the audience for their active participation, and I'd like to thank our team for arranging this webinar with you, sir. Thank you very much, sir. Thank you, one and all.
Thank you. It's my pleasure.
And sir, we are looking for many more webinars with you. Please.
Sure, Dr.
Thank
Stalin.
you, sir. Thank you
Thank
very much,
you.
sir.
Thank you.